which was shared during in December 2025. As we all know that the policy, making a policy document is quite an hectic process, and it was done with the extensive consultative process. And this time, the previous policy, that was the National Health Vision 2016 to 2025, was mentioned about eight pillars, priority pillars on which the health system needs to be to work on. But this time it is they have mentioned about the 11 pillars, priority pillars, which needs to be where the, and they have identified the gaps where it needs to be addressed and different. And if I can just narrate those pillars. So these are the good governance for the better health outcomes, fair and sustainable financing in health, and universal access to quality essential health services, responding to unfinished and emerging public health concerns, ensuring the population stabilization for sustainable development. Slides, please. We have prepared a small presentation to highlight these pillars. Next. Yes. And number 6 is addressing the malnutrition for the healthier and productive population. Multi-sectoral engagement critical for the better outcomes. Health security for the protecting the population against hazardous risks. A competent health and allied workforce, and access to essential medicines, products, and health technologies. Data, digitization, dialogue, and decisions. So these are all the pillars, but for the today's discussion, as the time is limited, so we have selected 4 areas which are quite important to discuss. Number 1 is the population, and then is the fair and sustainable financing in the health, and ensuring the population stabilize responding to the unfinished and emerging public health concerns, which will cover the family planning and adolescent and youth health, as well as about the legislation of different components of the family planning, and access to essential medicines, products, and the health technologies. I think this is just an overview of the policy priority areas for the discussion. And because this is a large document, and obviously it will take more time to explain everything, so I shared with all the panelists. So I will now start with Dr. Abid Suleri, who is Executive Director, Sustainable Development Policy Institute, and he is wearing different hats, to mention a few, and he is an active member of several national and global policy platforms, including the International Advisory Committee of COP29, ADB Institute's Advisory Council, and Pakistan Climate Change Council, and he is chairman of the board of NDRMF. So welcome, Dr. Abid Suleri. Please, for the welcome remarks, I would request you to welcome all the guests and also to give your insights on this policy document. Thank you very much.
Thank you very much, Dr. Razia Safdar. Good morning, good afternoon, good evening, ladies and gentlemen, depending from where you have joined today's webinar. And as Dr. Razia mentioned in her introductory remarks, this is a policy discussion that we have started trying to understand different contours of health policy financing, the anticipatory and unmet needs of emergency health services, anticipatory and unmet needs of adolescent and reproductive health issues, and just try to understand where we are today and what needs to be done. And I think for us, the entry point should be our highest household income and expenditure survey, which is just released last week, and the numbers they reveal a very stark picture of Pakistan's health policy landscape. Looking at the numbers, you will find that almost 57% of expenditures they are actually done on food and housing and utility. So whatever a household spends, 57% of it goes to food, goes to house rent, goes to utility, and then comes if you look at the health and education expenditures, health and education expenditures are less than 3% each. Now, if a household that is earning 100 rupees, $100, is only spending 2 rupees on health, that shows how neglected this sector is. And now compare it with the health allocation for different provinces and federal government in the overall budgeting scenario, and you will again find that most of the spending on public side too is on brick and mortar rather than improving health facilities and health infrastructure. And that is where whether we use the SDG lens, whether we use human development reports and human development lens, whether we use our population growth, which is 2.6%, and try to understand how quickly and how faster our health expenditure and our health policies are matching with this population growth. So we will find ourselves at the lowest rung of all the ladders. And that's why today's consultation and consultations like this, these are important so that we can bring back health on the radar of policymakers, try to understand its economic cost, try to understand its social cost, try to understand its economic dividend and social dividend, and try to ensure that we enter in this fourth industrial revolution as a healthy, nourished, and a well-protected society. And in this regards, work of Dr. Razia and her colleagues is very commendable, and STPI is looking forward to cooperate and work with all the relevant stakeholders to keep this discussion forward. Back to you, Dr. Razia Safdar.
Thank you, Dr. Abid, for covering all the areas of social health protection as well as the gaps in the health system, which are lacking on the delivery side. And so now we have with us Miss Dan Fang. Are you there, Miss Dan Fang?
Yes, hi.
Yeah, okay.
Morning.
So, good morning. So, she is, thank you very much for joining us. And she is a public health specialist with the World Health Organization in Pakistan. Her work focuses on improving the health and well-being of women, children, adolescents, and older people while addressing the key challenges such as nutrition, reproductive health, family planning, clean water and sanitation, environmental health, and impacts of climate change. Before joining the WHO office in Pakistan, Ms. Fang then worked at the WHO regional office for the Western Pacific in Manila and WHO in China on mental health, emergency response, and injury prevention with a strong focus on protecting vulnerable populations. Through coordinated action across sectors, she holds public health and policy qualifications from Peking University, the London School of Hygiene and Tropical Medicine, and the London School of Economics and Political Science. Thank you for joining us. I would like to, obviously with quite like a commendable portfolio. So I would like to ask you about how do you see Pakistan's health sector, particularly in perspective of policy, with the regional comparison and implementation status, I would like to invite for us your overview of this policy document or the previous policies in Pakistan. Thank you.
Thank you very much. Dear colleagues, thank you very much, and especially thanks to SDPI for the invitation for me to deliver this special remarks and for convening this important discussion on the draft National Health and Population Policy, plugging the gaps. So the breadth of expertise represented here, I saw that there's almost 50 participants online. So this breadth of expertise already reflects the complexity of the challenges we are addressing and the necessity of inclusive cross-sectional solutions. From the WHO's perspective, our role in this dialogue, I believe, is to help ground the discussion in global evidence, equity principles, and practical health system realities, with a particular focus on how policies translates into better health outcomes across the life course in Pakistan. So let me begin with the universal health coverage, which sits at the center of this policy. So from WHO's standpoint, Pakistan has made important commitments to universal health coverage, but the present status reflects significant gaps in equity, quality, and financial protection. Access to essential package of health services remain uneven across districts, gender, income groups, and life stages. Out-of-pocket spending remains high, and preventive and promotive services are often the first to be compromised. This brings me to public financing and alternative financing approaches. WHO's global evidence shows that financing reforms are most effective when they prioritize primary healthcare and vulnerable populations. While alternative and innovative financing mechanisms can complement public resources, they must be designed very carefully. They must align with health system objectives, equity goals, and fiscal sustainability. And financing should incentivize prevention, integration, and quality rather than fragmentation or hospital-centric services. Inclusion is another critical lens through which this policy must be viewed. So an inclusive health system is not only about geographical coverage. They're about who benefits, who is left behind, and why. So women, adolescents, people with disabilities, old persons, and populations affected by poverty or climate vulnerabilities continue to face disproportionate barriers. WHO strongly supports embedding equity-sensitive targeting and gender-responsive budgeting into implementation of the National Health and Population Policy. And very importantly, adolescent well-being deserves particular emphasis. Pakistan's demographic profile makes adolescence a defining stage for the country's future health and development. Yet, adolescents' needs, such as mental health, nutrition, anemia among girls, injury prevention, and access to age-appropriate sexual and reproductive health services remain insufficiently addressed within existing service packages. WHO's global and country experience demonstrates that investments in adolescent health yield lifelong benefits and contribute directly to gender equity, education attainment, and economic productivity. So that's a long-term investment. And this closely linked to gender responsiveness. Gender norms and power dynamics shape health risks, access to services, and health outcomes at every stage of life. I believe everybody is quite aware of it. A gender-responsive health system goes beyond maternal health. It addresses unpaid care burdens, access to information and service for adolescents, men's health-seeking behaviors, and protection from gender-based violence. WHO encouraged the use of gender analysis and sex disaggregated data to inform both financing and service delivery decisions under this National Health and Population Policy. Another fundamental pillar is the data integration and evidence-informed decision-making, which is also one of the 4 important topics that we're discussing today. As we see, fragmented health and population data system limits our ability to track progress and identify inequities and hold systems accountable. WHO strongly supports the policy's emphasis on interoperable standardized health information system that can function across provinces and sectors. Integrated data is essential for monitoring the universal health coverage, adolescent outcome, nutrition indicators, and gender disparities, and for ensuring that resources are allocated where they are most needed. Finally, I would like to emphasize that the success of the National Health and Population Policy will depend not only on its technical soundness, and as the moderator, Madam mentioned that it took many rounds of consultation, but very importantly, it lies on how inclusively it is implemented. So the implementation of the policy is the most important. This requires strong coordination across federal and provincial governments, meaningful engagement with civil society and communities, and partnership with research institutes and development partners and private sectors, like what we are doing right now, consultation among different partners. WHO remains committed to support Pakistan in moving this agenda forward through normative guidance, technical assistance, capacity building, and collaboration with all stakeholders represented here today, online, and even beyond. By collectively applying the lenses of inclusivity, equity, gender responsiveness, sustainable financing, adolescent well-being, and integrated data system, we can help ensure that this policy delivers tangible improvements in health for all across the life course. I look forward to the discussion and to working together with all of you to translate this policy into action. Thank you very much, and shukriya.
Thank you very much for your comprehensive overview of all the gaps and also to for further suggestions. And I think we are going to have a good discussion, and I would like to have a comment at the end also from you for the further what can we do further. So now, thank you very much. And now I will like to invite Ms. Samina Hassan. She is currently working as serving as the Executive Director of the National Institute of Population Studies, Training and Research, a premier research organization under the Ministry of National Health Services Regulation and Coordination, to produce evidence-based data in spheres of demography, population and development and health. She is Basic Scale 22 officer and has served on several key positions like Secretary, National Commission on Status of Women, Additional Secretary, Revenue Division, Senior Joint Secretary, Cabinet Division, and Senior Joint Secretary, Statistical Division Chief. And she has been working with the academic institutes also. So welcome, Ms. Samina Hassan. So I think as I have mentioned about the pillars which are very important and we are discussing today, one of this ensuring population stabilization for sustainable development. So we are the question from you is like, as your department or NIPS has made many researches as well as they have made many projections on the dealing with the population data. So I would like to ask, what is the current status of Pakistan's population projections from your recent work? And what impact would they have on the NFC award formula, as Madam Dr. Abid, as well as the previous Dr. Fang also mentioned about the fund allocations as well as the public finance management. So NFC award is very important for the provincial work to proceed. So and the population is the one of the criteria for the awards. So I would like to ask you this question. Please go ahead. Thank you very much.
Bismillahirrahmanirrahim. Good morning and assalamu alaikum to all of you. Thank you very much, Dr. Razia and Dr. Abid Suleri for inviting me over sorry, for this panel discussion. To start with, a word about my own organization, that you know that NIPS is a premier organization which is internationally and nationally recognized for conducting research in the fields of population and health. And can all of you hear me, please? Is it okay?
Yes, we are. We can hear you.
And it is it is also conducting surveys and data collection. So at the moment, we are conducting surveys like PMA, that is the Performance Monitoring for Action framework, under which we are conducting the longitudinal studies and surveys. In the past, we have been conducting PDHS and we have conducted PMMS also, and these were our flagship projects. But now, last year, we have conducted PMA and the population projection exercise. PMA is actually a very, first I would like to introduce a little, say a little about PMA, because PMA is a very sophisticated and it's a very technical sort of a survey. And it is basically, we study trends and patterns of family planning under this survey. It is conducted in the selected districts all over Pakistan in the 4 provinces. And then we study, it is basically a 3-tier sort of a survey that studies the household also. The questionnaires are addressed to the households. Then we also focus on the client exit surveys. And we also focus on the public service delivery centers, which include the public as well as the private sector health services. So these are conducted in the 4 provinces. Previously, we have conducted 6 rounds in Punjab, and we have completed 3 rounds in the other 3 provinces. So this is a kind of survey that gives us a clear picture about the status of family planning in the provinces. And then at the end, we disseminate the reports, and we go to the provinces and we talk to them. We tell them that what is the picture, what is the status of population, its allied challenges, and the family planning in their respective provinces. And we here target the women of reproductive age from 15 to 49. So this is something about PMA. The other exercise that we did was the population projection exercise. Here I would like to say that population projection is one of the mandates of NIPS. We have been doing that in the past also, and we have conducted last year also this entire exercise, which is a very, very hectic, and it is a very tedious process that we conducted a series of meetings. We collected and so many experts and demographers from all over Pakistan, and we made a technical working group on this, and then we made a subcommittee, which is a very small group working on the population projections. We have completed the report, and it has been a joint venture between the Planning Development and NIPS and the Ministry of Health, obviously. And we have completed the report and we have submitted it to the Planning Commission, but it has not been made public as yet because some fine-tuning and final brushing is still there, and we have to do it. So according to the population projections, what we have done is that we have focused mainly on three areas in the population projections. We are going to project the total population from 2023 to 2050, and we have taken the year of the census, that is 2023 till 2050, and we are giving the total population, we are giving the age and sex-wise population, and the spatial distribution also amongst the provinces. So these are basically the three things that we have done. Now, what we have done is that we have based these population projections on two basic assumptions. There are two assumptions that we have taken. One is a slow decline, which means that if this scenario continues and with the same policies and with the same interventions. And secondly, we have taken the rapid decline, which means that if active interventions are made, new policies are made, then what would be the population in that particular year, that is 2050. So as it has not been made public, so I'm not going to give any figures to you, except that in 2050, according to the slow decline assumption, the population of Pakistan is going to be 389 million. And if there's a rapid decline, then it's going to be 371 million. So, ladies and gentlemen, what I want to say here is that whatever surveys and whatever data collection we do point to the same thing, that the population of Pakistan is increasing at a rate that has become unmanageable. The growth rate is 2.5. Total fertility is 3.6. We are the fifth most populous nation in the world, country in the world, most populous country. And it is high time that we focus on this issue. And one of the ways of doing is to revise the formula of NFC award. Because giving 82% weightage to population in NFC award, I think we need to review it and we need to revisit it. And here a lot of debate and a lot of brainstorming is still going on, but we need some more discussion on it and some more indicators other than population or poverty and backwardness or inverse population density. Some other indicators must be added to it, which are like I think the population management itself should be added to it as one of the indicators, other than tax collection and human development index and women empowerment. The most important thing is population management as an indicator must be added to it, and some weightage must be given to it. So my point of view is that because we collect data from the provinces and we have also projected the population, so the picture is very clear that now it's the time to revise and revisit NFC award, and we have to add some more indicators in it and reduce the weightage given to population to some extent. That is my point of view. Thank you very much.
Thank you, Samina, for your very apt, I think, the points. We are going to be 389 million in 2050, which is a huge population, and already we have a large youth bulge, and which is and the employment status in Pakistan is is squeezing, and we need to look into and there are your NEPS is also a you are also holding the research and training departments also. You are you have NIPS and R&T. So I think your training facilities are also doing the capacity building of the family planning workers, family welfare workers. So how do you see that? Are they obviously on that one is on that splice demand side, supply side, that you are training the people who can go into the field and can work in the to improve the family planning situation. But what is the uptake of those workers after the training in public sector as well as in the private sector? Because there is in other sectors also there is a gap between the supply and demand side. So any comments on that, please?
Yes, Dr. Razia, this is a very, very pertinent question that we have been training family welfare workers in RTI. There are in total about 14 RTIs all over the country. And in Punjab, we have 4. And in Islamabad, under the Ministry of Health and under my department, there's 1 RTI in Islamabad. So before I comment on the other part of your question, I would like to introduce what we are doing in RTI. Regional Training Institute Islamabad functions as a capacity building arm of the health personnel and plays a central role in strengthening frontline service delivery through structured training of family welfare workers. Family welfare workers are community-based workers responsible for delivery of reproductive health service package finalized in ICPT conference held at Cairo. It includes providing family planning services, counseling eligible couples, maintaining follow-up with clients, and linking communities with health facilities. The core objective of training at RTI Islamabad is to equip the FWWs with sound technical knowledge, effective communication skills, and professional ethics so they can serve communities confidently and responsibly. Emphasis is placed on a quality service delivery, standardized field practices, and respectful client interaction to build trust at the community level. RTI Islamabad conducts basic 2-year diploma course, which is registered from Pakistan Nursing and Midwifery Council, and refresher and promotional training for family welfare workers. Basic training is designed for newly recruited workers and covers key areas, including introduction to the population welfare program, reproductive health concepts, family planning methods, management of side effects, infection prevention, community mobilization, and record keeping and report procedures. This is basically the sort of training that we are providing in RTI to the family welfare workers. After a 2-year course, obviously, they go to the field. And 70% of these family welfare workers get jobs in the public and the private sector. Private sector is more open to them, and most of them are absorbed in the private sector. But as far as the government sector is concerned, you see we have a limited availability of vacancies. And when the vacancies arise, they are advertised in the newspapers, and then they apply against those vacancies, and then they get absorbed against those positions. So I'm also doing a study on this issue also, that how these family welfare workers are absorbed, and what is the percentage actually who find jobs in the private sector and the public sector. But up till now, I'm really very confident, and I see also that most of them find jobs in the private and public sector very easily, and within a period of 6 months to 1 year, they get jobs in the private sector also.
Okay, thank you very much, Samina, for your I think giving an overview of the family welfare workers trainings, and it's a good thing that we like they are being absorbed in the private sector, and the private sector is welcoming them for valuing their skills, because training is one part, and like the keeping the pace with the market is another part, which is very much necessary. And these days we are working on other aspects also, like on the other skills, because the skills which are given to the young adults, for example, the NAVTAC or the TVETs. So usually there is a disparity between the demand side of the private sector and the supply side. So that is good if their 70% are being assimilated. Thank you very much for your points. Now I will come to Dr. Shehzad Ali Khan. Thank you very much, Dr. Shehzad, for joining us. I understand you have very like a busy schedule, and we can say that he is the public health in Pakistan. So he is currently serving as a Vice Chancellor of the Health Services Academy. His areas of research include the social health protection, health insurance, health systems and policy, MNCH, nutrition, implementation research, health promotion, every subject of the health he has covered. And he is wearing multiple caps at the moment. To mention a few, he is elected chairman of the Global Fund Oversight Committee for Pakistan. He is member of the Central Executive Committee for the Pakistan Health Parliament. He is member of National Steering Committee, Ministry of National Health Services Regulation, and has worked with several national and international organizations such as World Bank, WHO, USAID, UNICEF, UNFPA, all I think UNFPA, and UNAIDS, and also So, Doctor, we have, as you mentioned, that you have a meeting in the presidency. So, without any delay, I would like to ask, in the policy document, it is mentioned that there are different gaps. So, how do you see this draft policy document as compared to the previous National Health Vision 2016 to 25 in perspective of digital advancements and AI-supported functions? How the suggested actions are aligned with our existing health situation or the requirements. Over to you, Dr. Shehzad. Dr. Shehzad nahi? Phone karun. Okay, Dr. Shehzad, I think he is. Start with Dr. Saima Hamid. Okay, ठीक है. Okay, so Dr. Shehzad will join us later. So we can start with Dr. Saima Hamid. Welcome, Dr. Saima. Are you there?
Hey, Dr. Razia, very much
Thank you
here.
very
Thank
much.
you.
So she is also a public health specialist, and she is currently working as a program and research lead at Population Council Pakistan. She is also an adjunct professor of public health at Global Institute of Human Development. She is former vice chancellor of Fatima Jinnah Medical Women University, having earned her PhD from the Karolinska Institute. She has rich teaching and research experience in health policy, reproductive health, adolescent health, family planning, health systems, and implementation science. She is serving on the numerous working groups, committees like Global Implementation Society, board member, Research Excellence Work Framework, and the Women Empowerment and Monitoring Program. She has a lot of contributions in the public health as well as in the gender side. Dr. Saima, I have a question for you. that one of the public health challenges that the adolescents and the young adults face multiple health problems, including mental health disorders, drug addiction, injuries, and communicable diseases. And the proposed strategic action in the policy is that to develop a comprehensive programs that target the adolescents and youth with focus on health promotion, disease prevention, and adopts a multi-sectoral approach involving the education, sports, and other sectors. What is the entry point to start with? Like, is it through the health system, educational institutions, and other sectors with inclusive approach for these young people to look after their health and reproductive health issues? Thank you.
Thank you, Dr. Razia. And let me begin by thanking SDPI for hosting this discussion. I think it's a very timely initiative. And before I address your question, let me share that I was part of the team that developed the NHPP. The salient points have already been mentioned by Dan Fang, but let me reiterate that this document was prepared through a very inclusive process, and the priority public health issues were raised because many of them remained unaddressed to date. And one important pillar that has been added is that of multi-sectoral and importance of working with the other sectors. And I think that is what you raised in your question just now. That's really significant. At the same time, when we talk about a framework at the national level, it's important that once we decide what we need to do, we need to have a monitoring framework followed by some implementation guidelines. So these are the other strengths of the policy. So with this preamble, if I were to answer your question, I would say that there is no single entry point. The real effectiveness comes from, sequenced entry. But then again, somebody has to be the primary custodian. And in this regard, for the adolescent health issues, as you've mentioned, it has to be the health department and the ministries of health. So in Pakistan's health system, if we were to just reflect on what has been happening, I think the current pathway as defined in the NHPP is very much aligned to the ICPD conference in 1994, when it defined the reproductive health as and brought in the life course concept from birth to death, inclusive of both men and women, and was right-based. So if with this, if we think that adolescents' health, what is that entry point? Clearly, the custodian is the health sector, because what about young people? Their confidentiality is very important. You mentioned mental health issues, the drug abuse, the sexual reproductive health is again a very important area. And there, adolescents would definitely require confidentiality, counseling, and that can only happen in a sector that has the mandate for that. And currently, it is this mandate rests with the health system. We are committed to the primary healthcare. There are opportunities, there are facilities. So the real question is, are they adolescent responsive? So adolescent responsive services embedded within our existing primary healthcare, and the primary healthcare approach has clearly been highlighted in the document as well, is the need of the day. So, but because you see, there are other sectors that can play a good role, but until and unless the pathways are defined for the young people with the services, we will not be able to fulfill the needs of the youth. So when we talk about sexual reproductive health, nutrition, mental health, substance abuse screening, injury prevention, and so on and so forth, you have to look at it clearly from the lens of as a continuum. Like, while the awareness has to be there, then there are certain services that are present. So how do you bridge that gap? And that has to be defined through very clear pathways. So without anchoring it with the health system, adolescent programs will be at risk for becoming, mere campaigns. So currently at Population Council, let me share that the social behavioral change communication is a priority. We are working with our partners from GEO to develop these messages that are tailor-made to the clients. And of course, these messages do not operate in isolation. Until and unless they're based on evidence, they will not be effective. So while these different initiatives are important, I think the other very important thing that is brought out in the National Health and Population Policy document is the involvement of the private sector. So when I bring or raise all these issues, it's not the public sector alone that would be able to fulfill the needs. As Dr. Ms. Samina pointed out just before, that look at the huge numbers that we have at play. So until and unless we define some models that work, the public-private partnership is immensely important. But of course, the regulatory function will continue to vest with the government. About the coordination, you mentioned the other sectors as well. Definitely, coordination across sectors is very critical, and that's the reason why the multi-sectoral pillar was added to the policy document. Again, the health sector alone can only look after a slice of it. It's very important to yet bridge these different pieces together and have a holistic approach. I think one of the colleagues earlier said about coordination as well, and that is pivotal to bringing about that change. Whatever we do, by the way, has to be based on evidence. The evidence-informed decision-making will not only just help these different gaps, but also it's important that there is in-house capacity to do the course correction. So there are lots of opportunities that we know of at the federal level, at the provincial level. It's about how we implement them in an effective way. So when I say this, what I'm saying is that we have been talking about interventions. So in this particular case, the adolescents, the intervention actually starts much before that. The points of entry or the platforms could be the schools, colleges, and universities. But please remember that there's a huge chunk that remains out of school. But let me just focus on the ones who make it to this platform. So there are clear opportunities at hand. So if we were to apply the holistic health programs that cover the priority areas, address the burden of disease, rather they're aligned with the burden of disease that we have. Clearly, Pakistan is, we have done a burden of studies. We know that what kind of communicable, non-communicable diseases are out there. And these messages are rather neutral. So with these messages under the larger health program, we can address mental health issues, nutrition, and then the life skills based education can be included in the curricula as well. Because this is not a one-time event or a program that happens at one point in time and that's the end of it. No, it will graduate to the next level, or adding more curriculum to these different initiatives, because all these curricula are basically age appropriate. So the right-based health information, the age-appropriate messages will not just are the starting points for the low-hanging fruits for the population that makes it to these educational institutes. But in a way, the information actually goes or trickles into the community as well. So it will help normalize the conversations around especially mental health and reproductive health. So by linking the students to the health services is the mandate of the other structures, not to replace the health sector, by the way. And this, of course, would benefit clearly the girls and the young women. Like Ms. Dan Fang earlier said, the equity is the focus. So these are the kind of issues that would clearly help us define our strategies as we translate our policy into the strategies at the sub-national levels, and especially at the district level. It's important that we take into account the kind of information that we have access to. Recently, Population Council launched its District Vulnerability Index for Pakistan. This, in fact, index is based on multi, indicators from different domains. Like it takes into account the household, the communication and transport, livelihood, access to health services, access to education, while linking it with the demographic information as well. So you see, other sectors can clearly play a role, but when we look at population issues holistically, of course, the segment that addresses population and the adolescent health needs or services is being responsible for a segment of it. I'm not saying that there isn't a need for a youth policy or a population policy. It needs to be vested elsewhere at a central level, and then it has to be integrated with the sector-specific policies. So when we talk about other sectors like the sports and youth affairs, even social protection, that's where I feel as an academician that there are tons of opportunities there. We need to provide spaces where creativity is fostered. The social service element, is embedded in the university level education. Entrepreneurship is being promoted. The work of these these initiatives can lead to the workforce participation of women. So when we and for those who are not going to these universities or educational institutions, we could look for other potential entry points. Like for the boys, it's easy to have sports clubs, but for the vulnerable population, a lot of another initiatives for nutrition related, health related platforms could be used. And in today's day and age, the digital platforms certainly are one way of addressing the needs. And this is where it's very important that we look at the larger picture and see what is doable. And whenever we look at the interventions as to what is doable, the first principle is to focus on the low-hanging fruits, implement them in that entire slice to see the effectiveness and then scale up. So I hope that satisfies you.
Thank you very much,
question.
Dr. Saima. I think you have comprehensively covered many of the whole subject about the adolescent, and then, but rightly said that it should be evidence based. But don't you think we have enough evidence to work for the problems of these adolescents and the young people? Recently, we were talking about the mental health. I would like to mention about the recent incidents. We talked about the vulnerable populations as well. But in the high-end private university, they had two students who committed suicide. One attempted suicide, and who committed committed suicide. So, what is lacking there? I mean, they have the digital information. They are the private university. They have all how do you see that public-private partnership, and how do you see that? And the other question is, like you said, that the health is the entry point. That's true for the adolescent and for the young people, but who will bring them there? Because mental health and also the other reproductive health is still to discuss, is still a taboo for them, even for the young girls who are married early, and they cannot talk about the family planning things in not even in the people who are not educated, but the girls who are educated, they feel shy on that. So who will bring them to the health system? What can be done on that? There is a lot of evidence on that the family planning, since it is started, so interventions, whatever they have done is not like, it's not global in Pakistan, and also the outcomes which we were expecting,
Moving forward.
it's still not, we have not met the targets. So what is your point on that?
Thank you, Dr. Razia. This is not one question, but I'll try to, not omit any of the questions that you've raised. So you talked about evidence. Let me address that first. As far as the evidence collection is concerned, of course, a lot of information is being collected. The research is very much there, but it's I, in my recent years, have I'm more inclined towards the implementation science models now. And the reason is that the evidence is there, but it is not utilized effectively by the relevant stakeholders. Sometimes the information lies statically, and we have seen that in the health facilities within the systems. And this was one of the major discussions why we went for during this exercise of the National Health and Population Policy drafting. So there are models. For instance, Population Council has proposed a specific tool, a tracking system with one of the provinces that will facilitate the triangulation of data from different sources. Now, what is the problem over there? Of course, when we talk about data, there's a lot of confidentiality attached to it. Then the systems, compatibility comes in. But most importantly, in my opinion, it's the capacity to process and utilize that information. So so these the initiatives are in pipeline, but I feel that often enough in a lot of these kind of discussions, we say there is a lot of evidence, but that knowledge translation is exceedingly challenging. Recently conducted survey in one of the provinces showed that practically all almost 80% and above women knew about modern contraceptives who had never used it, but then none of them, or in fact, the knowledge was really high, but then they didn't know where to get it. So there are clearly, simple steps that can bridge this gap. So this is one huge challenge that we have, and this is compounded by the fact that we don't have to look after 3 or 4 people. We have tons of people to. The sheer magnitude of the population makes these the translation efforts challenging. I wouldn't say ineffective, because they have been trial tested. Some initiatives, when they're tested, they definitely make a budge somewhere. So coming down to the other, incident that you mentioned within the university, one of these incidents are reported. There again huge challenges within the universities as well. So I'm glad that you brought that out, given that I have had the opportunity of leading one of the public sector universities here. But what my take on that is that, especially after COVID, the HEC promoted, counseling and wellness centers. And as a mandate, all of the universities have those centers established. Mostly, they are being run by their psychology departments, or somebody independently is responsible for that. For instance, in our university, we had a policy to sort of train our faculty so that they pick up the signs of, say, anxious students, or so that they could refer them for counseling. And this facility was available for the staff as well, and the faculty as well, and it was being used. Now, we have to look at this incidence in light of what our burden of disease is showing. We have a high prevalence of mental health issues. Are we, in fact, have we overcome the stigma attached to it? We have not. But I can clearly say that mental health is increasingly acknowledged in higher education policies. How it's translated, of course, varies from institution to institution. And HEC does recognize the importance of student counseling and well-being services. But as far as the reproductive health concerns, the issues are concerned, students do seek out sexual and reproductive health. They do come to these facilities for that. But what kind of the insights are that at the institutional level, most of the people are uncomfortable discussing this, and there is a lack of structured guidance around it. So some of these things may be happening at one point, but they are not happening at the others. And you've rightly pointed out that who will bring fine. And I never said that. I said this is the first anchor point is the health systems. But then, by that I mean that the services have to be there, which are adolescent friendly. But then again, how in isolation, health will never be able to bridge this gap. So who is going to bring people to these facilities? We need to change the social norms. And how does that happen? One of the first intervention is that with education and providing safe spaces to the women and our youth, by the way, and getting the voice in of the men folk as well. So if I were to sort of capture this entire thing holistically, I would say that when it comes down to the adolescent issues, particularly pertaining to the, even the drug abuse, the policy within an institution, the educational institution at the university level exists. But currently, the framing is such that if you report a person abusing or rather using abusing a substance, like substance abuse is present, then it starts a chain reaction, and there are lots of reporting that is required that may even put the student at risk. So people are very apprehensive about the next steps. So policy alone, without looking at the how it's translated, becomes very difficult. I'm not saying it's not a good starting point, because harassment policy came in a few years back. It was revised, revamped. Even the modalities were redefined. So we have to implement them in full spirit, and then see how those are taken up, and they move forward from there. But one area of, the family planning, like I said, the sexual reproductive health needs are clearly seen. The questions, young people come in and ask those questions. So they need a safe space where their needs could be, or they could be guided rather. So the educational institutions could be the entry point, but then they have to refer them to a facility that would really look after them well. So for that, how about the providers? Well, currently the way situation is, the adolescents already, after their fertility intentions are defined, well informed by the, informed, or rather they're imbibed by them through the social norms, it's already too late. So currently our family planning, in fact, programs reach out to them only after the first or the second child is born. Then the silence, the misinformation, and the trusted channels for the adolescents is yet another challenge. So until and unless we have the whole system or the framework in place, of course, these issues will remain challenging. But a word of caution over here that I would like to make over here. Currently, people see educational institutes as a safe space for women. So you cannot, you have to package these reproductive health related interventions or knowledge. You have to package it in such a way so that it is well received without raising red flags anywhere. So that's another challenge. Of course. So what is it defining now? So the multi-sectorality is very important. Health's role is, as far as this service provision is concerned, but then that pathway has to be really defined and every sector has to take on their roles. But when we talk about the health sector, it's very important that we already see it in health. There are so many missed opportunities. For instance, despite facility-based deliveries, and I'll digress. I mean, this applies to the entire, women of reproductive age group. The family planning, along with all of its elements of counseling, is not offered to all. So it's the institutional delivery may be high, but it drops down to 25% to 30% of what I mean. People come for ANC but don't get counseled on FB. Then they come for the delivery, they don't get counseled. Even postpartum, family planning is not implemented. They come for abortion care, post-abortion care, but family planning, again, the guidelines are there, but they're not implemented. So what is happening over here? Could it be the providers? Could it be one way, one challenge that has happened after we've been talking about integrating health with population welfare? So what is going on? Clearly, the health providers need to be oriented to the family planning trainings as well. And there is this, the provider-client interaction that needs to be improved. And that communication channel alone is not just applicable for family planning. It would suffice all their needs, whether it is a communicable disease, a non-communicable disease, or for that matter, it's MNCH, nutrition, or family planning. So again, there is evidence. Like I said, you need to know what works. There is evidence that there is a Sahar communication training of healthcare providers, both for the facility as well as for the community workers. And now with the recently, launching of community level workers in different provinces, there are lots of opportunities that go unnoticed. So my point is that the policy, this translation needs to be done, I mean, has to be translated into certain effective strategies. And that certainly has to have happen at the subnational level.
Okay, thank
I
you very
hope
much.
that I've covered your points. Yeah.
Yeah, thank you very much. I think you extensively covered it, but like when we talking about the sexual and reproductive health, so we need to be inclusive in that case to include the adolescent or the young youth or boys as well. So because that is like you must have seen in the social media and all this, but that is a separate discussion, but that is a sensitive point also. And we need to discuss in detail, and we need to provide the safe spaces as you mentioned about that. So I think we have, please stay with us. I have another question for you, but in the end. So now we will come to the very important and core issue of the implementation of the health policy, that is the financial aspect of this. How do we deal with the finances or the public finance management? So we have Dr. Jahanzeb Sohail with us. Welcome, Dr. Jahanzeb. Jahanzeb Sohail, are you there? Yeah, okay. So Mr. Jahanzeb Sohail is a senior health economist at World Health Organization, at World Bank. Bank's Health, Nutrition and Population Global Practice Global Office, and he leads the Health Program of Advisory Services and Analytics of Pakistan, overseeing the lending operations and supporting regional health financing initiatives. He covers areas of the universal health coverage, as Dr. Saima has mentioned about the universal, and he is domestic resource mobilization for health, strategic purchasing, and public finance management for the health. He has also played a key role in advancing UHC initiatives, contributing to policies that promote the equitable high quality healthcare services. Thank you very much, Jahanzeb, for joining us, and congratulations for your recent work on the universal health coverage. I had a chance to see on the LinkedIn you have posted, but it was really commendable, and I think we are going to the right direction. So for this webinar, I would like to, regarding the policy, and one of the challenges in the policy for the public financing of the financing is that there is a 50% out-of-pocket current health expenditure, and even with the SHP, social health protection, the vulnerable populations are exposed to the catastrophic expenditure. So the strategic interventions talks about the financial risk protection by transitioning from out-of-pocket to prepayment means through enhanced tax-based financing and social health insurance. My question is that what are the prepayment means and how we can enhance the tax-based financing, as we are always talking about this, but effort was done previously also, but still it is not implemented. And what are the barriers to the implementation of these issues? Thank you very much.
Thank you so much, Dr. Razia. First, I would like to appreciate the efforts by STPI for organizing this important webinar, and also pleasure to be part of among the esteemed panelists, and also glad to see many of the familiar names as attendees of this webinar. So with regard to your question, first, I would like to mention that we do know, and I try to be very structured in terms of response to you, so I won't take much time. So with regard to your question, I would like to mention that out of pocket, when we mention it, so for a decade, it stays roughly at the 50%, and it is not really a good or welcoming situation. We can consider it's a gruesome situation for Pakistan. Out of payments for Pakistan is what we are paying for health services, whereas our constitution is saying that health is considered as a welfare subject. So it's a contradictory that why we are paying for that, and definitely it requires system for that. But important point is, what is catastrophic healthcare expenditure in Pakistan, and what is the impoverishment level if we pay for health? And surprisingly, I want to mention here, there's no recent study for that. So we have been claiming, the last study I did back in 2021, based on 2018 and 19 PSLM and HIES survey, we identified it's only 6% of catastrophic healthcare expenditure. It can be very, very risky if we go above 10%. But personally, as a health economist from the World Bank, I doubt that we have recently launched so many initiatives. Our expenditure tracking is aligned what we are showing. So it's another debate, but in short, I really wanted to mention the out-of-pocket payment expenditure high, catastrophic expenditures, we don't know. Impoverishment level for health, we don't know about that. So that's the one thing. Secondly, you mentioned what is prepayment means. And here, apologies, I'm going to give you some more detailed information, though many of you already know, but what I see the audience is not really familiar with the financial or technical jargons related to the health financing. So prepayment means what we say, that if any of the person gets sick, it should be paid before being sick. That's the prepayment. And in our case, Pakistan, we have 3 modalities to do this. Well, overall, globally, we have 3 modalities. But and what are these? The number one is it should be already paid through tax, so tax-based financing. Number 2 is we say the mandatory social health insurance, and it's a payroll deduction. It's a mandatory, and all the formal sector is supposed to get this done. This is very, very famous in Germany and many of the other countries. And there's actually 2 main models have been created based on tax-based financing and as well as social health insurance, Beveridge and Bismarck model. And I'm sure many of us has already studied during our studies. So, and the third is private health insurance, which is a voluntary. So prepayments in case of Pakistan hugely dependent on tax-based financing. In Pakistan, we have a formal sector, which is, as per labor force survey, recent one, it is 27%, which is already not welcoming. So that means there is, if we really want to go for the social health insurance, mandatory payroll deduction, it's going to go up to only 27%. And we also know that there's a poverty, people are living below poverty, which is roughly 40%. So that means we have 27% who can pay and 40% who cannot pay at all. And there's also informal sector in between that we call it a missing middle, from where we have to get the payments, which is another gigantic task. So in short, in prepayment system, we have only option left is tax-based financing. This is like the background information. And why I see the tax-based, because the voluntary is not really equitable. The third part after your question is, let's say, how we can enhance the tax-based financing. To be honest, as the public health practitioner and health financing, it's a very broad topic. And much of the discussion goes towards how we can broaden the tax-based system for that. And for that, we see for the past many years, our tax to GDP ratio remains stagnant up to 10%. And we have been coming up with many times ambitious, I wouldn't say ambitious, it's a doable, but it seems ambitious to go up to the 15%. And we failed to do that for many years. So still in this budget cycle, we again claim that let's go for 15% and let's see when we can get that. To broaden the tax, actually, it requires many steps. I mean to say, it must be linked with the reduction in exemptions and tax holidays, enhancement of GSTs, which is not favorable again, and they also improve the tax administration system, which is also a big challenge for us. So that's the part A of enhancing the tax-based financing. The second could be the sector-specific revenue generation. In Pakistan, we have been relying on public financing. We never touch upon the alternate options. One of the, I wouldn't say one, but among many, one of the options could be taxing the products which are injurious to health. So in many countries like Philippines, there's a tobacco taxation, alcohol taxation. In Pakistan, we are heavily dependent on sweet and sugary beverages. We are using a lot of ghee and many other products. So there could be one option to raise the revenue on through this. So that's the second part. If we enhance the tax so that sector-specific revenue generation can play the role. Thirdly, we need to earmark them, and it can help that how we can advance for that. So earmarking in Pakistan, considering where we have a fiscal federalism and considering the health as a devolved subject, again, a big challenge. So what I see that in terms of talk, it seems reasonable, but in terms of practice, it requires a high-level fiscal reforms if we really, really want to support our agenda, in particular with this policy or any sector strategies at the provincial level. Over.
Okay, thank you very much, Jahanzeb. I think you have rightly mentioned about these, like the 27% are in the formal sector and who are going to pay for and 40% is the poverty level. So who is going to pay for them? So regarding the taxes, like you mentioned about the sweetened beverages and tobacco and alcohol, and recently the Saudi Arab has done, I think, good job. They have put, I think, 100% excise on the energy drinks. So how do you see that? How can it be implemented? Because previously also there was an effort to put the sin tax on the tobacco, and what is the the barriers in implementation of these strategies in Pakistan? Can you highlight on that, please?
Sure. So you're absolutely right. So interestingly, I've been a part of developing the health financing strategy for KP, and KP is among the first provinces who's coming up with the health financing strategy. And we were discussing heavily that how we can have more resources. In case of KP, again, bringing it at the spot is KP is one of the provinces that is relying 92% of the finances from the federal. So their own source revenue is only 8%. So this is the high time they really need to enhance the revenue. Similarly, not only the enhance overall for the province, but also for health. So currently they are spending, if I'm not wrong, 276 billion in this budget out of their overall outlay of 2.2 trillion PKR. So it seems like they require more funds. And one of the options could be the sector-specific revenue generation. You rightly mentioned the tobacco. Kepi is one among the provinces who has the tobacco production actually. So how they can do this? So going into the deeper discussion, we realized two main challenges. Number one is tax administration, as I already highlighted. It's quite cumbersome and complex and beyond health. So it requires senior level leadership who start owning it, that how we can really take it forward. Number one, at the provincial, the federal level. Number two is dissonance between federal and provincial structure. So excise taxation, which is applied at the tobacco or sweet and sugary beverages, it's collected by federal. And if it is collected by federal, no matter provinces are going to put all those efforts, is there any guarantee that whatever the revenue is being generated or collected from the provinces is going to be routed to the provinces? And excise taxation again comes to the constitution and many other things, created many legal reforms. So which becomes a very cumbersome and challenging thing. We as an advocate for the sector-specific revenue generation is always pushing for that, but keep that in mind. Finance looks at it very differently. We are pushing because it's injurious to health. If we tax the tobacco, number one, it can help to raise the revenue. Number two, it will reduce the burden of disease, which is a win-win for us from the health perspective. But finance sees that it also offers employment. It also is a production. It also offers some services. It's an industry. So if we tax them a lot, it will reduce the overall bucks for that. And again, the discussion related to that, how much we are generating revenue and how much room we can increase. Calculation shows that we can go up to 150 billion PKR if we apply the excise taxation, enhance this to the tobacco. So these discussions are going on. The ultimate solution could be federal and provincial structured, streamlined approach, that how we can take it forward beyond health. And most importantly, ownership, which are like linked to the finance and many other departments or ministries to take this agenda forward. So it's a process is on the way, but seems daunting. And hopefully at some point we will get some results.
I have another question for you. I think these days we are talking about as Ma'am Dan Feng also mentioned about the alternate financing or innovative financing. So what is the scope of innovative financing mechanisms like bonds, guarantees as instruments for financing in other sectors? How it can work in health sector? We recently worked on the different mechanisms of the these innovative financing, and we did I think at SDC Sustainable Development Conference also there we did a big panel on that, and high level panel on that, and there were many like instruments discussed, as well as many international practices were discussed also. So how can we health can be benefited from these innovative financing mechanisms? Please comment on that.
Sure. So considering we have very limited fiscal space, even though our economy is getting some stability and inflation is under control, but if you look into the overall picture, I'm just relating to the first question, we are investing roughly only 1% of GDP, which is very meager. And we should go up to 5%, but at least 3%. So in this case, what we need to have, what options are left? We really need to come up with the innovative financing. Innovative financing is very famous in low-income countries. It is highly pushed by many of the donors, to be honest, especially who are managing vertical programs, because what we see that if we bring in private sector, it will help in low-income countries and low-middle-income countries. So now, what is actually innovative financing? What we mean, what do we mean for that is these are the financial actually instruments, and we use it to mobilize the additional resources to shift the risk and also pay for outcomes. So it's sort of a better idea to do this. And many of the example you rightly mentioned, that we have impact bonds, very famous in education and many other areas. Social impact bond has been very important in India, by the way. Similarly, guarantees, blended financing. We have also result-based financing and green bonds, sustainability bonds, health bonds, and many others. Now, taking all of them, are we in a position to introduce in health? Yes, we can, but there are the two things. Number one is we need commitment, senior level commitment from the government of Pakistan. Number two is, and of course, the modalities. And number two is we really need to understand and realize how much potential we can generate considering our economy. So here we are talking about that right now we are investing roughly 1.3 trillion PKR. It seems a really high number. 1.3 trillion means 1,300 billion PKR for health. If you count all of the provinces who are spending up to in our recent 2025 budget and 26 budget, so this number comes up. And if you look into the total picture, we are investing 3 trillion PKR in health. Again, seems a really, really big number. Now, this is ongoing picture. So the remaining part is coming from the out-of-pocket, private sector, and all those. So innovative financing, how much they can bring it or add up. So Punjab is already spending 550 billion PKR in health. If we introduce any of the innovative financing, how much more revenue we generate? In our numbers, what we see, not more than 20 billion. So the efforts behind this are huge, but the outcome at the end, we're gonna get not that much. But anyway, the initiative is really good. So let me explain that how we can introduce. In health, we can introduce actually what we say the health bonds. And health impact bonds can be that we issue that if we achieve 90% of immunization, any of the investor actually agreed to invest on it, government can be a guarantor, can pay back based on the KPIs, and any of the service provider, made the Department of Health or made any parastatal organization or whatsoever, can be the service provider. So this can work, health impact bond, but for this we need the foundations, we need local bank, we need investors that who should take it forward. Second thing is blended financing. We come up with a mixture that where the public financing goes with the commercial private market, and the private financing comes in, and we offer them the de-risking, and I mean government, and come up with some solution where the private entity takes the lead, and with a little financing, maybe from IFI or government or something, guarantor from the government side to do this. So this is a blended financing. This can really, really work in digital health. This can really work in diagnostic. This can help in local production of family planning commodities, nutrition commodities, and many other. So this blending financing can be another example. Third, I would say that we also have result-based financing. Many of the NDBs, including my organization, World Bank is involved, where we see that if the results are met, we introduce disbursement link indicators. So if they are matched or achieved, so the disbursement will happen, result-based financing happen. So this is taken up by World Bank. This is taken up by ADB, one of the big programs, National Health Support Program that I'm leading. It is working on this agenda actually. So these are the couple of examples to take it forward. There could be many others like guarantees for infrastructure we are doing in Sindh, and many other things we can do this. But again, more or less in all means, we need viable economy model where the private sector is really, really interested to go to the social sector in terms of generating some profit. Meanwhile, government has to ensure that they shouldn't hike the profit and offer the quality, considering that the poverty is really high. So it's a very tough condition, but doable. But overall outcome picture is not really high level, but the initiative is good. And it will definitely support and sensitize the donor agencies that Pakistan is a country that is considering the other options as well. So which is a really positive point. Over.
Thank you very much, Jahanzeb. I think it's like as you said that NSHP is on result-based disbursements. So what is your, I must say, I think it's a long discussion, but we can do it at another time. What are the outcomes for that? Definitely, I think that there is the regulatory environment which needs to be implemented in Pakistan for this type of financing mechanisms, and also the banks and a lot of I think sectors needs to be, and in this policy, national health and population policy, one of the identified challenge for the financing is the system inefficiencies, leading to the resource wastage and non-utilization due to poor public finance management, lack of understanding of innovative provider payment methods, and slow transition from passive to strategic purchasing. As a strategic action, implementation of the fiscal reforms like digital PFM system is proposed and will help to transitioning from passive to strategic purchasing of the health interventions in private and public sector. So my question is how it can be implemented, digital public finance management, and how it can particularly focus on the private sector, because private sector is the main the health delivery provider, health services provider in Pakistan. So please give your thoughts on this. Strategic purchasing and public finance management.
Right, very well. Thank you so much, Dr. Razia. So one important comment I want to add here for health policy is number one, I really like it, and it covers many things. And if you look into the core is relying on PHC, which is really impressive. But it also adding very big, let's say, jargons, and it is covering or encompassing many things. So why I'm saying that, we have mentioned digital PFM. It's huge, and let me break down my response quickly. So the number one is we all agree that even though we are spending 1,300 billion PKR in health, our health outcomes are poor. We are getting loans, but we are not receiving the results. All right. So this is the one challenge. And if you look into the systematic issues into it, so 1,300 billion PKR. Take out little cost for capital, which is 10 to 15%. Remaining cost, 60% to 70% goes to the salaries. And the last, whatever the 500 billion PKR is remaining, that's your operational cost. And now you're talking about the improvement of services. So that's the structural inefficiency into the system. Secondly, we also see the overall the business of public financial management is having so many inefficiencies, whether it's planning of the budget, execution of the budget, reporting of the budget, right? Our midterm expenditure frameworks, and similarly the annual development plans and all those, everything. If you look into in the details, we see that there are so many glitches and hinges. Just giving you an example, health department, when they seek to getting the money, so there are roughly 19 points to get the funds from Treasury to the DHO, let's say. So who's going to do this, those receipt and many things? It requires digital efforts. It's very important to mention that Pakistan has already done a lot of work on digital PFM, and we are among the one who actually, based on that, the other neighboring countries has taken. I'm referring to IFMIS. Integrated Financial Management System, information system is one of the ideal one in Pakistan. However, we can question whether it is applied in true spirit, and particularly with the health sector. I would say yes, in true spirit it is applied, but for health sector there are many issues and challenges. So your point is very valid. We have to improve the digital PFM system. Digital PFM system is already rolled out, but now we have to contextualize or adapt for health. Just quoting example, looking at the PFM system, object-wise and function-wise codes. Our function-wise code doesn't segregate the primary, secondary, and tertiary level. Our function-wise codes cannot tell you that how much money you are spending in let's say vaccines. Even though, well, in vaccines we have worked a lot, but let's say in TB. So because Our practice is putting every information into the others. Our practice is putting every information into the general medicine and something, all that. So that's the one challenge. Second thing is digital PFM also require e-procurement system. KP has started doing it. Punjab is also struggling and doing it, and Sindh as well. But this is mandatory, considering that we have red contracts, we have many challenges in terms of procurement. So this is also part of into this, that if we really want to enhance. So what I wanted to mention, the digital PFM is a big thing, huge thing. It requires heavily funding, heavily technical expertise to revamp the system. And many of the institutions are involved into it. However, our health part, what we see that we do have also inefficiencies. You mentioned a word or coined a term, strategic purchasing, which is essential. Just to tell the audience, right now we are doing the passive purchasing, where we are not doing or putting any efforts. Budget is transferred based on historical norms or trends, right? And we are not seeking for the optimal results or KPIs. There is nothing into it. But what if we do that and we apply the proactive approach, introduce KPIs, contract management, and many other things to enhance the quality? That's the strategic purchasing. In terms of financing, innovative financing mechanisms, purchaser provider mechanism, we are using a couple of them. Number one is line budgeting, which I just explained, that the historical trend. Number two is global budgets. Number of the hospitals are receiving the budgets based on like the services. And sometimes we also offer single line grants, like in case of Sindh, PPHI is receiving single line transfer or some of the grant transfers, right? So these are the three core. But for strategic purchasing, you should have a contract. You should offer them based on that contract. And this requires legal framework, this requires governance mechanism, this requires regulatory mechanism, this requires digital system, and most importantly, oversight and monitoring. And these all are lacking. Right now, Pakistan, considering our service delivery proportion is 35%, 65% is coming from private sector. This is a high need. Like, we really need to collaborate with the private sector. We already introduced public-private partnership for health. We have PPP units and nodes working in different provinces. This is the time to strengthen, and they really need to introduce the contracting out services model in a true spirit. Current one is not really ideal. So this could be the one way. Similarly, DHOs is receiving money, except like Sindh and Punjab, let's say in KP. So DHOs are receiving money based on line budgeting. So why we are offering line budgeting? We can change the modality for that. So this is like the ways forward. From the other side, we have started working on it, and many of the other organizations are keen to work on it. So let's see what we get out of it in the coming next 2 years. I would highly suggest that let's do a webinar in somewhere, let's say after a year, and see the progress that what we are up to, because many of the organizations, while drafting this health policy, committed to chime in and play a role into it. And let's assess their role and also the outcomes of the policy as well in the coming days. Over.
Jahazib, I think I have taken liberty to ask you many questions, but it was really important to highlight these issues as well as to explain, because the financing is the core of any program or any health services. Or thank you. So we have, I think, Dr. Shahzad, are you there? So Dr. Shahzad has joined us, rejoined us. So Dr. Shahzad is Vice Chancellor, Health Services Academy, and he is the public health in Pakistan. So, and he's wearing many caps at the same time, and he's a part of the steering committee, which is for health at Ministry of Health. And Dr. Shahzad, I will ask a broader question first to you. How do you see this draft policy document as compared to the previous National Health Vision in perspective of the digital advancements and the AI-supported functions? How the suggested actions are aligned with our existing health situation and requirements? Over to you.
Thank you, Dr. Razia, and sorry for the interruption. I had another meeting, emergency meeting, when I had to attend for 15 minutes, and then I joined back. This draft, I have seen the methodology and the way forward and of course, the usage of the building blocks like we use in the health vision, national health vision. I was part of the National Health Vision working group in 2016. I was one of the consultants who developed two chapters. One was on financing, and other was on this human resources in health. So when you talk about population policy and you talk about a population policy which is being developed by health, so it's altogether a new, game changer in Pakistan, because previously all the population policies were developed without the consultation of Ministry of Health, mostly because I have an experience of around 32 years in public health. I never, saw any population policy in which there was some usage of the six building blocks or usage of the integration and the model of service delivery and governance and everything, use of technology, commodities, everything was like like not integrated, it was fragmented. So it's very good to see the six building blocks and the eight sectoral dimensions which we use in National Health Vision converted into four main themes, and then talking about the population development and population policy. This is good to start, because for the last 20 years at least, maybe more than that, we have been advocating the integration of population services with health. Not just integration of population, but also nutrition. So the World Bank, like you see, you heard Jazeb, the World Bank also has HNP. So there is no single health sector even in the World Bank, which is the main multilateral agency of the world for different projects. They call themselves as health, nutrition, and population. So we need to think like this. So when Pakistan has an integrated policy of health, population, and nutrition, only then can things be improved in all the three sectors. Otherwise, nothing will improve in health or in population or in nutrition even. So that is my answer, that it was a very good draft. And I have some written comments, and I'll share it to you separately on the draft. Ji,
So,
Razia?
Ji. Thank you, Dr. Shahzad. I think one of the challenges in this policy is like the social health protection initiatives do not target the vulnerable groups. The intervention package is not evidence informed. Primary care interventions are not included, and administrative costs are substantial. And the programs are non-contributory, thereby posing a significant financial burden on the government regarding the social health protection. So, as you are part of the steering committee, and what is the future of this program? Because it
Yeah,
is like benefiting the like vulnerable populations.
yeah.
But what is your
Actually,
take on that?
thank you. If I answer to the statements and the questions you mentioned, my answer, like you use one very common answer in multiple choice questions, which is all of the above. So when if I tick mark what you have said, all of the above you said are correct. They all are correct statements. Why? Because the targeting concept in the world versus the universalization. It had always been a debate whether to target the poor or create the systems in which every poor gets benefit. And it's a long debate. But when it comes to Pakistan, the out-of-pocket spending, just focus on one thing, out-of-pocket spending. Jay-Z, Jahzeb talked about 1,300 billion spending in Pakistan. The around total expenditure, according to National Health Account, is over 2,000 billion per year in Pakistan, which means there's a huge amount of not only the government spending, but also a huge amount of out-of-pocket spending is going on in the country. And if you identify the incidence of poverty, so we are not talking about currently how to eradicate poverty. If even you want to reduce the incidence, and what is incidence? Every year, how many new people come into the poverty line or they go below poverty line? The highest incidence of poverty is created by catastrophic expenditure leading by this out-of-pocket spending. So there was a Center for Poverty Reduction and Income Distribution supported by UNDP in Pakistan in the Ministry of Finance. I myself and Dr. Sania Nishtar, we used to work in that department as a consulting from Heartfile. And I was working with Social Security at that time, and it was also a health insurance scheme. So we found out that 56% of the poverty incidence. So if 100 people go below poverty line every year, 56 of those new poor, they become poor because of a health shock, because of a catastrophic expenditure. So health financing is one of the most important, not only the determinant of poverty, but also it's the solution of getting people out of poverty and prevent people from getting below poverty line. And that was the reason for social health protection, which was started. And then it was the reason it was started, and we tried to at least reduce this incidence of new people going below poverty line, and also take out those who are below poverty line and they are unhealthy. Okay, this initiative was started as a targeting scheme for BIS beneficiaries, PMT score 32.5. So we are actually having this problem, but then it was universalized. By I universalized, I mean it was open for everybody. So if there are certain services and you say these services are free for everybody, then you mean that these services are there for the powerful, the mighty, and those who have contacts. So if you don't do evidence-based social health protection schemes, the poor doesn't get the benefit. So what we are doing now is for the next 2 years. So tomorrow, Prime Minister of Pakistan at 9 a.m. in the morning is inaugurating the restarting of the Prime Minister Qaumi Sehat Card scheme. So it's the Sehat Sahulat program with a little bit of changes. So the Qaumi Sehat Sahulat program, Prime Minister Qaumi Sehat Sahulat program will be launched, inaugurated tomorrow. It will be initially for Islamabad, AJK and GB. And then hopefully we are also talking to the Punjab government. We are also talking to the Sindh government. Inshallah, we will be coming up with the future expansion. Balochistan is also, Balochistan health card is also in the pipeline, almost launched. But there are certain things to it. That would be for initially for 2 years that would be government support. Then the third year there will be a co-pay. Yeah, you mean the affording segment, the people who have a certain level of income. They will be contributing 50% in the third year, and then fourth year they will be contributing 75%. And then in the fifth year, we will have a proper social health protection scheme where the poor will get free services, and the affordable class, voluntary or compulsory in the form of a government servant or any else. So there will be an option of you and me to enroll yourself into the Sehat Sahulat services for a monthly pay of premium. So it will be around 500 per family, which is not much. I don't think it is anything which is difficult to pay. 500 per month, 6,000 per year for the whole family. I don't see any harm in just 6,000 rupees a year, and you get a comprehensive coverage of indoor and a lot of other services. This is again on, and it's a good news because finally we are again going into that social health protection scheme. There will be an evaluation. The previous evaluations have shown that we were able to reduce out of pocket spending to some extent, but not that at which we needed, and that was because of a lot of experimentation on the Sehat Sahulat program in different provinces and also in the federal level. Over to you, Dr. Azia.
Okay, thank you, Dr. Shahzad. It's a good news. And one question, is it targeted still, or which tomorrow is Prime Minister is going to launch? Is it targeted or universal?
It is universal. It is universal for 2 years, and then only for the poor, it will be free. Others will co-pay.
Okay. Thank you very much. And Dr. Shahzad, another question is for regarding the policy. They said that it is improving the regulatory environment for the private sector engagement. When we talk about the private sector engagement and establishing the
government sector. What the government hospitals are doing with 13 billion, 14 billion annual budgets, when nothing is available, almost most of the things are purchased from the market or from the front laboratories. If you see the government hospital, every government hospital in Pakistan, just across that government hospital, you will find a huge network of pharmacies. What is the reason of having the pharmacy in front of a government hospital? It means nothing is available inside and you have to buy a. There is a network of laboratories in front of the government hospital. There is a network of private clinics in front of the government hospitals. So my take on this is, whenever you talk about private sector, make some enabling environment in which they are happy to serve the government, they are happy to serve the patients, and in doing so, they get certain incentives. Not everyone is greedy. People are trying to, contribute in the national cause. Our attitude is wrong. By our, I mean the attitude of the government officers, the attitude of the government departments. They are not enabling. They are not giving them guidance. They are not giving them, in proper incentives. So private sector is like an open enterprise. They don't need your or my support. They are currently filled with patients. A huge burden of disease in this country. 4 to 6% Pakistani need admissions every year. Multiply it by, the percentage, this percentage by 250 million. You will understand how many people are in need of, hospital care, indoor care. OPD is another story. 2 visits per person per year, almost every. So for 25 crore, 25 crore, 50 crore OPD visits are required minimum in this country. How many are happening? Almost very, very few, maybe 20% of this. So the point is, when you talk about in your policy document, is actually we have to inverse whatever we have been doing. We have been using the stick for the private sector and we have been using the carrots for the government sector. It should be the other way around. If you are giving the money to a government sector institute, ask them with a stick. No more carrots for you. And give the carrots to the people who are voluntarily working for the cause of the country, for nation, and they have created huge investments. Billions of rupees are spent in creating a hospital, and they are providing your services of those hospitals to the Pakistani population with the partnership in a government. So I think this is something which we should provide and know that how to do that. The whole globally, the private sector is the most respectable, entity or stakeholder in case of a government and private sector dealing. They respect those chamber of commerces. They respect those hospital union associations. Yes, there are black sheeps. There are people who are extorting money. They are doing a lot of things. Then there is the role of a healthcare commission. They can do that. There's a role of PMDC. There's a role of a lot of other statutory bodies. So I think without the involvement of private sector, Pakistan can never achieve universal health coverage. Azeb did a very nice, talk about public-private partnership, the PPP node in Sindh and other areas. Now all the political governments, and I can say very frankly, all the political governments, whether it's PTI, whether it is the People's Party, whether it is Noon League, whether it is MQM or any other political party in Pakistan, everybody is convinced. I have met all of them, the leaders of all the political parties. Every political party is confirmed that they are actually convinced that in Pakistan, if you have to go for a universal health coverage or a good plan, good health system for the country, you need a public-private partnership. Public-private partnership cannot be achieved by a stick only, by regulatory requirements and compulsions and contract negotiation with one side, a powerful stake on one side and nothing on the other side. So we should be first of all creating enabling environment, enabling organizations, institutional mechanisms, not just policy. Policy is nothing. To support the policy, you need an institutional requirement. Like, there is a Public-Private Partnership Act in KP. There is a very, very excellent public-private partnership model in Sindh. So we can learn from those models, whether they worked or not, and then create an enabling environment. Instead of stick, provide carrot and stick formula to, and of course, a lot of training, capacity building and advocacy for the private sector. Only then Pakistani nation can have good access to health services. The government services are not enough. And our Minister Mustafa Kamal on a daily basis, just see the previous 1 week statements he has given. He always said the burden of disease is so high that no government of the world can provide services for this burden of disease. We need to prevent, We need to promote health, we need to protect, we need to vaccinate, we need to do breastfeeding. So he is talking about public health for the last, say, many months. So it's a very good sign. And he will definitely be up for public-private partnership. He always supports public-private partnership. So if the federal is doing that, the provinces are always convinced. So I think that is a very, very good hope for us. Over to you, Dr. Razia.
Thank you, Dr. Shehzad. It's good news that the minister or the high-level political commitment is there for enabling environment to the private sector as well. In our recent study also, it showed that the private sector responded really well for the improve the quality of services during the Sehat Sahulat program era in the previously. And I think they need more support, and the more the pat on their backs, so that they can really, and they are really motivated to do that. Because the population of Pakistan is such that it is not possible for we cannot work without the private sector. Thank you very much. I think we are coming to the end of our webinar. We had questions, but we will be replying individually, because now the time is short. So for the last comment, I would like to invite Ms. Dan Fang for the final comment in perspective of this discussion happening. And one point I want to make, that this is the first of this webinar, and we have discussed about the 4 pillars, and then we will continue discussing the other pillars as well. As we would like to thank you very much, Dr. Shehzad, for joining, and I think we will take the advice from all the health experts and financial experts, and we will continue. We will have a series of webinars for this. And thank you very over to you, Ms. Dan Fang. Thank you.
Thank you very much, Madam. So it really humbles me to speak, give comments after hearing this excellent panel discussion. So I find there's a lot of knowledge, a lot of activities, data, and interventions already going on, and I do not have more to add. But I also hear that when it comes to implementation in Pakistan, there are many factors to consider and there are many challenges. But my humble ask here is, despite that we highlight it's important to design the system in a very inclusive way, we should not wait for anything to start implementation. So we could start and make baby steps in every front, so towards the goal. When the design is there, I mean, the design should be comprehensive and inclusive, but implementation can start when the best condition is not ready, when the best evidence is not ready, or even when the best data or willingness is ready. Whenever there is an opportunity, let's start doing something, so that we can see the impact, and that will actually create a positive momentum for us to expand and scale up some the interventions. The it's time that we break the silo and look at the health and population in with more cross-cutting horizontal perspectives, and to build links, build more linkages. So that has multiple layers. One is even within the health system. For example, we mentioned that there's fragmented service. There's perinatal separated from family planning, or so each service is by itself. It's provided by itself. It's not provided taking the patient as a whole person. So we should break the silo of services. We should provide people-centric services rather than service-based services. And then goes beyond the health system. We need to also look at health from not just the clinical perspective. We should look at the social influencing factors. My belief is health should be in more policies, and thanks to Dr. Shahad, that he reminded us that not just policies but institution to establish an institution to enable this cross-cutting, horizontal, interlinked service and systems to enable health and create a win-win environment and incentive systems so that we can bring all the partners together for the ultimate health outcomes, including the public-private partnership. So I feel we are all on the same page, and the knowledge is so abundant. I feel humbled. But now let's continue the discussion of other pillars. At the same time, we could think about some of the action points that we can start implementation. Back to you, Chairperson.
Thank you very much, all the panelists, Ms. Dan Fang, Dr. Shahzad, Ms. Samina, Dr. Saima, and Jahanzeb Suhail Saab. I think it was very rich discussion, and we would like to, we will try to bring out some the key points, and we'll share with you. And for the participants, we will post it on the LinkedIn as well. So we thank you very much again for for your time and for your support. Thank you very much. Thank you, my team also, Khadija and Alishba. They both worked hard, and I think we will continue discussing this, and this was very enriched discussion. Thank you very much. Thank you. Thank you.
Thank you.
एक
Thank you.
screenshot